This patient came in via EMS on a stretcher. She was kind of altered to begin with, so we couldn't get much of a history from her. What we did know was she didn't have a seizure history before.
But we were told that the patient had had a couple of seizures while they were bringing her into the hospital, and that when she got there she was pretty confused in like a post-ictal state. She was agitated, couldn't really answer my questions, was just kind of thrashing around in the bed. Her vital signs were very abnormal, blood pressure was very, very elevated, and just overall a very ill-appearing person.
From that point on, we took a look at her entire body to make sure there weren't any injuries. And I remember distinctly also looking at her abdomen, like checking for any tenderness. We looked to make sure she was moving all her limbs. She can feel us like touching her hands, arms, things like that.
We were definitely trying to think of things that would cause a seizure, worried about some sort of head bleed, an intracranial hemorrhage, could possibly be even new onset epilepsy. We were considering toxicologic causes. A lot of people had mentioned, the triage nurse, the paramedics had mentioned that they were concerned the patient was going through withdrawal. Still didn't quite fit the picture, and so didn't really feel like that was probably the most likely thing, but it was of course always something we had to consider. Ordered a CT scan, we ordered some lab work and an EKG. She had received some Ativan right after arrival by the nursing staff and the intern to try to help stop any seizure that she might be having. We also went ahead and loaded her with Keppra to try to prevent seizures as well. We were worried about the patient and that she was pretty sick, and we were trying to get the workup going pretty quickly, but didn't know exactly yet what we were dealing with. It wasn't until about 45 minutes into her stay at the hospital that we figured out what was going on.
I was sitting down and reviewing her chart, and it stood out that she had given birth. Other things, anytime you hear that a patient was recently postpartum or had given birth or further along, you get that like feeling, you know? And so as soon as I saw that, I went up to Dr. Freeze and I was like, Dr. Freeze, this patient had given birth a couple of weeks ago. And I remember the moment when I saw her eyes just go.
And so I said, how far along postpartum? Are we talking, 6 months, or are you talking, a very short amount of time? And she said she was a month postpartum. And when she said that, I immediately knew the diagnosis and I felt sick. I knew we had missed what was going on and we were going down the wrong path. If we hadn't figured out that the diagnosis was eclampsia, I don't think we ever would have used the magnesium. I think we would have continued to treat her in the ways that we would treat someone who was not postpartum. And had we done that, she could have continued to have seizures.
She could have had kind of worse bleeds, permanent damage from it, and there's a possibility she wouldn't have survived.
Here at UAMS and at some of the other emergency departments I've worked at in the state, whenever a patient is over 20 weeks pregnant and up to about 6 weeks to the postpartum state, they will go directly to labor and delivery if they present to the emergency department. So I think a lot of times we assume that when we get a patient in the emergency department, if they are pregnant, they're either very early on, less than that 20 weeks, or they have not, they're not pregnant or they have not been pregnant recently. And so I think a lot of times we kind of forget to think about that. I think that hospitals that don't have obstetric services, this is going to play out a little bit differently in those areas. My hope is that those physicians, because they don't have OB, they are a little more vigilant for these cases presenting there. But at the same time, they won't be able to kind of hand off the patient as quickly as we were able to, and so they'll need to be able to manage that patient a little longer. It's really important that they stay on top of their, OB-GYN knowledge. They know how to manage these, antepartum and postpartum emergencies until they can get the patient to the place where they can get the care from the OB docs.
as emergency medicine providers, we are that first, I think of it as like we are the triage for the hospital. So once we get a patient and we are the first people to see that patient, having that wide differential and making sure the patient goes where they need to go and get the treatment they need to is important.
We have to be vigilant. We have to always consider when a patient comes in that they could be in a postpartum state or they could be pregnant. I think emergency medicine physicians do a good job of considering that patients are pregnant very early on. We get pregnancy tests on most of our patients, but we don't always think that they could possibly be in that postpartum period. And so I think we just have to really be vigilant and keep that in the back of our minds and consider that as a possibility. There are certain things in emergency medicine and in medicine in general that are diagnoses that you can't miss and that everyone should know. And seizures in a postpartum patient being eclampsia is one of those diagnoses. Just something that you need to learn in medical school. It needs to be something that you continue to learn through residency. It's going to be on board exams and things like that. And it's just one of those things you have to know because it is a true emergency.